Our next speaker from the Academic Unit of Neurology at Trinity College Dublin, Dr. Miriam Galvin is with us by Zoom. Oh no, Miriam is actually here, isn't she? Is Miriam here or is she on Zoom? She's Zoom. She's Zoom. Miriam, you're on Zoom. Good morning.
Good morning. Good morning.
Lovely. I can see myself there, but I know we can hear you, so we should be able to see you as well. And I'll happily, there you go, lovely to see you, and I'm delighted to hand over to you now to take over this part of the presentation, which is on the caregiver experience.
Okay, thank you, Jonathan. So you see that I'm not Orla. So I'm here twice, so excuse me, but Orla and I have to go on to something afterwards, so she's very kindly let me sit in on her desk. And thanks a million for inviting me, and I'm also very grateful to the IMNDA for supporting some of the work I'm going to talk about now. So I will just share my screen. Thank you. Okay, so hopefully we can. Are we seeing that there? Yeah, is that okay, Jonathan?
Yep.
Great. Okay. So I'm Miriam. I work in the Academic Unit of Neurology in Trinity College Dublin. Basically, I'm going to talk today about the caregiver experience, but it's part of what we call patient journey research, which is a slightly different type of research than Professor Hardiman's just spoken of, because obviously the search for the cure goes on and the care goes on parallel to that. So this is looking at the patient journey through the illness and his or her caregiver, the informal caregiver, and family. So I showed some of this when I was at the another meeting there. I think you saw it there, Jonathan and Lillian, and I just wanted to talk a little bit more about it. So here we go. So what I look at is an ecosystem, and it's basically a set of nested relationships. So if we see the individual here, family, community, health service, and society. So not going into too much detail, and it's not supposed to be difficult or detailed to understand. It's just to show that all of us, as we know, are located within some connectivity to somebody else. So the idea of using the ecosystem approach to look at health services and healthcare is the approach that I take to a lot of my research, and it's also an approach that's being incorporated into precision ALS, of which Professor Hardiman spoke earlier. So if we just look at this individual, all of us are located ourselves. We may have a family, we may have a kinship network, we may not, but there's obviously a distant cousin somewhere is going to come after us. We're within a community, the health service and society, and the idea behind this is if something changes in one or other of those spheres, it generally has an impact on something else in another sphere. So we're all interrelated. So in terms of clinical care, then, if we apply the ecosystem idea to clinical care, we see the patient and carer, and I'm calling it a dyad, which basically means the patient and his or her main carer as a couple. They may not be related as a couple, but the dyad is the expression I use to just basically make the unit, while recognizing the individuality, of course, of both. The unit is what we're looking at here as well. So they're the center. And in the clinical care ecosystem, just for diagrammatic purposes, we have the Beaumont Clinic, for example, healthcare professionals in green, and community healthcare professionals down here in blue. It shows the different interactions among the clinical professionals, among the community professionals, around the patient and carer, and with the patient and carer. So that's the type of patient journey in a more of a spherical object. And here we have it in a linear way. So the patient journey and carer journey, and they're both parallel in this work. A lot of the work that's been done so far, and as I say, thank you very much to the IMNDA for funding some of this work, and going forward, hopefully, we've been able to collect a lot of information on clinical information, but also things like how often people, go to hospital, how do they travel to the clinic, what is the psychological health like, what's the burden? And burden is kind of a pejorative term, but it's just a general term to talk about the impact of caring on the caregiver. So we've collected all this over time through Beaumont, and thank you very much to all the people who participated in this research. And I'm just going to show some of the outputs from this research just this morning or afternoon. So initially, just to look at quality of life. So that's a very kind of loaded term. Quality of life isn't always health related. It isn't always health related, which is an interesting phenomenon for people in a disease context. So if we look at patients and carers' quality of life here over 3 time points, which is 3 interviews, it's interesting to note that out of 100, the carer seems to have a lower quality of life than the patient. That's not necessarily remarkable in itself, except most people's perceptions would be that a patient or anybody suffering or encountering an illness would have a lower quality of life. But as it happens, the data show that the carers actually have a lower quality of life than the patients. And just to say again, these were collected in parallel. So we know exactly what was going on at the first interview with patients and with carers. So it's a really, I believe, a really interesting way of looking at people's experiences and how they're feeling over time. This is an interesting one as well, I think. We looked at the difference from the third interview to the first interview amongst these particular dyads. So if we look at the very left of this graph, we see green is the patient and orange or yellow is his carer. In this case, for this actual dyad, and these represent actual people, they're not, it's not a diagrammatic, it's a diagrammatic representation, but they are actual people. So the first couple, if you like, on the left, their quality of life, for both people, fell from the third to the first interview. So in other words, by the time of the third interview, they said they had a lower quality of life. If we follow that pattern across, we see, interestingly, that sometimes the carer quality of life actually increases and the patient quality of life goes down. If we go across that graph towards the other side, we see patient quality of life increases and their carer quality of life reduces over time. And I think it's important to note that that there are a lot of we mentioned the interrelationships, but also that if one person is feeling good or well, it can have an impact on the other person. We know that the caregiver does not have the condition, the disease of note here, but they also have other issues going on, and therefore their quality of life is reduced. And we need to support the carer, the informal carer in this case, and also the professional carers, because we need those people to be able to support people living with ALS and motor neuron disease. Just going into that a little bit more, and you might have to stop me, Jonathan, I might go too far into all of this, so time-wise. But if we look at actually what people say contributes to their quality of life, and again, you'll see patient and carers split here. It's obvious that family is, for all of them, is the most important contributor to their quality of life, and in varying degrees across their hobbies. Interestingly, patients, that is people currently living with ALS and MND, believe the hobbies and their social activities are actually really important contributors. And when you look at the carers' hobbies and social activities, they've probably sort of taken a little bit of a hit because of their caring duties. So they become less important for these particular carers. And again, just to bear in mind, these are all data collected from people attending the clinic. So they're real data from real people. Splitting it by sex or gender, interestingly here, if we look at female carers compared to male carers, female carers have a lower quality of life than male carers. Other interesting questions again. And I think just to look at this is exploratory and it's very busy. But if we just take the patient males as blue, as they tend to be, and females as pink. So on the left hand, I have, if you like, male carers, I beg your pardon, female patients. So we have pink female patients, and on the right-hand column, we have male patients. So we don't have to get bogged down in the detail. I suppose what I'm just showing you here is it's called a congruence within each couple over time. So you see those lines represent, particularly if we just look at the first one, that they start with a similar quality of life, if you like, and the patients goes up and the carer goes down within that coupling. And you can see a pattern happening over time. So this is other work we're working on. So as Prof. Hardiman mentioned, part of our research is very much integrated with what's happening in Europe and the wider world. And we have the opportunity to use research from there as well.
About 5 minutes, please, Miriam.
Okay, so this is a cross-cultural way of looking at carers. So in the UK, the Netherlands and Ireland, which are part of our partners, we looked at what's burden like. And burden, as I say, is a combination of factors. It's considered psychological. So for carers in Dublin, if you look at that box on the left, their average burden is the line in the middle. It's actually lower than carers in Utrecht in the Netherlands and in Sheffield in the United Kingdom. So it's interesting to using the same measures. If we look at psychological distress, again, the only thing that's noteworthy here, one of the only things, is if we look at the lower graph, it's anxiety. Anxiety is higher amongst carers in Ireland than Utrecht or Sheffield. But having a reference population in different countries is really, really important. just to bear in mind that there are also good things about caring, and we all started to look at this recently. And this is a particular thing about Ireland and the Netherlands. So meaning in life, personal satisfaction, all of these things have been told to us that are important and become more or less important over time. In this case, we're looking at, again, on the right-hand side, you see the difference in the frequency of these things in Dublin and in the Netherlands. Meeting the patient's needs seems to be really important. It's not that it's not important in Ireland, but as a proportion of all things, meeting the patient's needs in the Netherlands seems to be their priority compared to, say, in Ireland, meaning in life derived from caring is really important. So again, looking at the over time in this case, this is currently in review at the BMJ, and we looked over 5 interviews, which is the longest we've ever looked at. And if we look at the green line is the total burden for carers, and the blue line is the hours of care provided, which increase with over time. So it shows obviously how the burden is related to hours of care, but not necessarily always, because there's not that much of a difference. If you see there's a difference in the hours of care provided, burden increases, but not as dramatically as you would expect perhaps. Again, another expectation, here we go, this is just graphical. Hours of care per week greatly increases. Psychological distress increases, but not massively over time. Burden does increase over time. And quality of life pretty much stays the same. So it's an interesting point, again, looking at quality of life, that it's not all health related. It's not, a lot of other things are factored here, and this is where the ecosystem approach. And finally, just to wrap up here, we asked, what are some of the good things over time about caring? And again, meaning in life and personal satisfaction. Fun and enjoyment comes out, relationships, being able to care. So this is a brief overview of what research is going on in the patient journey at the moment, patient journey data. And we hope to continue doing this in the Precision ALS prospective data collection that was mentioned. And we'd really like to continue with this internationally. And thank you very much to the IMNDA for the support of this work, and hopefully continued support. Thank you.
Thank you, Miriam. Thank you kindly, Miriam. We'll throw it open to the floor if anyone has any questions for Miriam here. If any have come through on the Q&A, I'll have a look as well. Has anyone got a question for Miriam? Yes, indeed. You might say your name again at the start, please.
Hi, thanks. My name is Maureen. Just a very quick question. What was the time between the interviews, between the 1 and the 3rd or the 5th?
Okay, the 5th one was approximately 2.5 to 3 years. And that's the longest one we've done. So over the course of 3 years, which is obviously a major length of time in the course of any illness. So it's really given us a very good insight. Generally, we like to do these type of interviews, if that's the way we're collecting data, every six weeks to maybe 3 months would be the interval there. But it is 2.5 years, yeah. Thank you.
Lovely, thank you very much. Have we any other question from the floor? Lovely. Okay, Miriam, it's been lovely. Thank you so much for talking to us. Dr. Miriam Galvin, ladies and gentlemen. Thank you, Miriam. Okay.